This is Jose Merino, Editor-in-Chief of the Neurology family of journals. The Neurology podcast provides practical information to neurologists and other clinicians to help them provide better care for their patients. Thanks for listening and have a great week.
Hello and welcome. This is Justin Abbatemarco from the Cleveland Clinic, here with Ilya, Ayzenberg, and Marius, Ringelstein to discuss their article published in Neurology, Eculizumab use in Neuromyelitis Optica spectrum disorders, routine clinical care data from a European cohort. Ilya is from the Department of Neurology and Ruhr University in Germany, while Marius works at the Department of Neurology at Heinrich Heine University, Dusseldorf, also in Germany. Hello and welcome.
Hello, Justin.
Thank you so much for joining. And I think you did a nice job in your introduction highlighting this explosion of new therapies we have for EQP4 positive NMOSD. We recently did an episode on June 17th, 2024, highlighting the high mortality within the Danish NMOSD cohort. So highlighting how vulnerable this population is and how important it is to have targeted medications like Eculizumab and other complement inhibitors available for this population. Can we talk about this new class of complement inhibitors, how they work, what side effects we should all be aware of?
Yes, Eculizumab, which we investigated in this study, is a humanized monoclonal antibody which has first been approved for the treatment of paroxysmal nocturnal hemoglobinuria and atypical hemolytic uremic syndrome in 2007 and 2011. It was first licensed in neurological disorders for generalized myasthenia gravis. It was first used in 2009 or 10 in NMOSD. And the complement system is a crucial pathway in the pathophysiology of NMOSD. And because the aquaporin 4 IgG, the specific antibody of the disease, binds to the astrocytic water channels and activates the complement pathway in the disease. And Eculizumab, as I said, a humanized monoclonal antibody, binds to the terminal complement protein C5 and inhibits its cleavage into C5a and C5b, and by that inhibits the destruction of the astrocytes. And considering safety, one has to say that the risk of meningococcal infections has been estimated to be 2,000-fold higher in patients with Eculizumab compared with untreated populations, meaning meningococcal vaccinations or antibiotic prophylaxis is mandatory in patients treated with complement inhibitors. And what we know from the phase 3 trials, for example, the PREVENT trial, there we didn't see any big difference between placebo-treated patients and Eculizumab-treated patients concerning adverse events or serious adverse events. And we only saw one particular patient who died on a treatment with Eculizumab, but not related to meningococcal infections or possibly related to the treatment agent.
I think it's a really helpful introduction to this class that we've had some experience with this medication outside of the field of neurology, which is always helpful. But I love that point about this medication targeting the underlying pathophysiology of the disorder, which is so important. It helps make the case of its effectiveness. The meningococcal organism, right? It's an encapsulated bug. So we need the complement systems. As we look into your data, so your group looked retrospectively at all EQP4 NMOSD patients across many centers in Germany and Austria. It was a relatively small cohort of 52 patients, but this is a rare neuroimmunological disorder. But what did you find when you dove into that data?
We have several key findings. Similar to the randomized clinical trial, Eculizumab was effective in preventing NMOSD attacks in the real-world setting. The most important difference was that we observed high effectiveness even in patients with a much more aggressive disease course compared to those in the PREVENT trial. The median EDSS disability score in our patients was 6.0 at the start of Eculizumab. MRI data also supported its strong clinical effects. But another surprising and concerning finding was that some patients experienced new NMOSD attacks shortly after receiving the meningococcal vaccine. We observed this in several patients who were vaccinated before starting Eculizumab, but in no one of the patients who were vaccinated while on Eculizumab. I think this is an important signal that needs future investigations.
Ilya, the effectiveness of the medication was really impressive in this cohort. Can you talk a little bit about that vaccination piece and the relapses associated with that?
To provide more details on meningococcal vaccination and post-vaccination relapses, we observed them in 7 out of 36 patients who were vaccinated before starting Eculizumab. But no one of these patients were on prednisone at the time of vaccination. In contrast, no relapses were seen in patients vaccinated while on Eculizumab or in those vaccinated before Eculizumab start but who were on oral prednisone. This suggests that prednisone might have a protective effect, although, and this is an important point, we still do not know how relapse treatment, oral prednisone, or other concurrent or previous immunotherapies affect the meningococcal vaccine response. Probably we need to investigate this point in the future studies. For now, in practice, there are usually 2 approaches when starting Eculizumab or ravulizumab therapy. The traditional one is to give the meningococcal vaccine 2 weeks before starting treatment. Alternatively, you can start therapy immediately with prophylactic antibiotics such as penicillin and then vaccinate later. In the second approach, antibiotics can be stopped 2 weeks after vaccination. Personally, I prefer the second, safer option as it also allows earlier treatment initiation. It could be crucial in some cases given the clustering of attacks often seen in NMOSD.
I really appreciate those points around the vaccination, right? It's so important to make sure these patients are vaccinated from meningococcal. It's recommended for 2 weeks, but then bringing up these practical points in, how we do that, right? These patients are usually acutely hospitalized, really sick. We have that concomitant prednisone, and we know that vaccinations could potentially worsen disease. So this is some really interesting findings and more to come. I think that other point that we are able to use maybe a combination of vaccinations and antibiotics, prophylactic antibiotics for short periods of times to help cover these patients, which it sounds like you did in your cohort and maybe do in clinical practice. Is that right?
Yes, so what we believe it's probably the best way to start with antibiotics immediately. Now, there is probably another point that vaccinating patients shortly after relapse therapy, we actually do not know what is the vaccine response, if there's any effect of relapse therapy on vaccine efficacy. So it's probably to vaccinate a bit later, but for sure we need more studies to investigate effect of previous treatment, including relapse treatment on the vaccine response.
Another really practical point, right? These patients receiving usually high-dose corticosteroids, we know that can impair vaccine response. Plex, just some really key, crucial pieces that we still need to figure out. Maybe along those lines, Marius, I know the majority of your cohort was previously treated with rituximab, which I think is similar to how our NMOSD cohort looks in North America. What prompted that switch to Eculizumab, and how did those patients do, especially in light of the immunosuppression that we know that rituximab or other CD20s can potentially cause?
You're totally right that in the past, most of the patients were treated with rituximab until the new monoclonal antibodies came to the market. In our cohort, one can say that the majority of patients, meaning 75% of them, had received at least one immunotherapy prior to Eculizumab. Some patients also received 2 or 3 or more immunotherapies before. And the most frequent therapy before Eculizumab was rituximab, given to 31 of 52 patients, meaning 60%. However, in the last 6 months, which are the most important time before the switch to Eculizumab, only 21% were treated with rituximab. And the main reasons for initiating Eculizumab treatment was the activity, or in one patient also the discovery of asymptomatic MRI lesions. To start or to switch to Eculizumab was the acute disease activity in 65% of patients. In the other remaining 18 patients, the reasons were disease activity more than 3 months before Eculizumab start, or side effects on previous immunotherapies, or refusal to reimburse other treatment options. Of course, we are aware of the problem that if patients are pre-treated with rituximab and are B-cell depleted, we do not exactly know the effect of the meningococcal vaccination, for example.
I really think the data around the disease activity prior to initiation to eculizumab really puts your data about eculizumab's effectiveness into context, right? We think of rituximab as relatively effective for this disease. 65% switching due to disease activity is impressive, and then to see a really strong efficacy rates within the eculizumab treatment thereafter, I think is really important. And then, Marius, I really like that point. How do we think through the immunocompromised status, vaccinations, the risks for infections moving forward? I think, again, some unanswered questions and things the field needs to be thinking about. This medication is infused every 2 weeks. How did most of the groups manage that? Were they placing a port? Did these patients get home infusions? How did they approach that medication?
We didn't ask this specifically to all the centers. This was a multi-center study, including 21 centers, mostly in Germany, but also one in Austria. I think, and my personal experience is that the patients are treated mainly at the referring center, meaning they come every 2 weeks to our center where they get infused, which is, of course, could be a logistical problem for the patients. Some of the patients actually do have a port. This is also a very small number. I personally know 1 or 2 patients. This is not required, but in some cases, when the patient really has bad veins, it can be necessary to ease the treatment to get a port. I'm also aware of the home infusion possibility. We do not use this for our patients, but I'm aware that I think Alexion offers this system, but I think none of our patients was treated with home infusions. And I think what is also important to know and to solve these problems of repetitive infusions every 2 weeks, we have a subsequent complement inhibiting treatment option with ravulizumab, which is available on the market since last year. And this substance also showed a very high efficacy and safety and is only administered every 8 weeks in comparison to Eculizumab, which is infused every 2 weeks.
Yeah, that medication ravulizumab was just approved by the FDA, I think, this year. So yeah, another medication that physicians and their patients can consider and work on, given the challenges with maybe a more frequent infusion like eculizumab. So really helpful there. Were there any other major safety signals seen in your cohort? I guess we've talked about infections. Did you see meningococcal or other encapsulated infections in this cohort?
We observed some safety concerns. 7 out of 52 patients had serious infections that required hospitalization. While this may seem like a high rate, it's important to consider that this was a cohort of severely disabled patients with multiple comorbidities. Only 2 of these 7 patients were on Eculizumab monotherapy, while the other 5 were also receiving additional immunotherapies such as steroids, azathioprine, and mycophenolate. Therefore, a direct link between Eculizumab and these complications is unlikely or at least questionable in all patients except one dramatic case. Unfortunately, one patient did develop a meningococcal infection and further fatal complications.
Yeah, I think we've seen that in other populations like our MS population where pre-existing disability, immobility, age, right? These are all risk factors for infection. So something to think about as we consider which medications for, again, this vulnerable population. Marius, maybe we could end on some take-home points. What should the general neurologist be aware of with this class of medications and using it within the NMOSD cohort?
I think what we take out of this study is, on the one hand, that we could confirm the high efficacy of the drug concerning relapse rate reduction, also MRI activity and disability stabilization. But on the other hand, we also found these possible safety concerns considering the post-vaccinal relapses, which occurred in the 2 or 3 weeks after the meningococcal vaccination. And Dr. Ayzenberg already explained other regimes to have vaccinate these patients before or during the Eculizumab treatment. And I think what we also should take out of this study is that there might be some safety concerns which have to be taken into account. For example, age or higher disability measured by BDSS, certain comorbidities, and also the pre-treatments, immunosuppressant pre-treatments have to be taken into account before making the decision to treat patients with these highly efficacious complement inhibitors.
Ilya and Marius, I can't thank you enough for your time. Again, our listeners can check out the article in Neurology. It's Eculizumab use in Neuromyelitis Optica Spectrum Disorder, routine clinical care data from a European cohort. Thanks again, guys.
Thank you.
Thank you very much, Justin.
This is Stacey Clardy, your podcast editor. If you've enjoyed the podcast, please take a few moments to subscribe, rate, and review the Neurology podcast through Apple Podcasts, Google Podcasts, Spotify, or wherever you listen. And remember, you can always head to neurology.org/podcast for our full list of past episodes. Or you can also search by keyword in your podcast app for any neurology-specific topics you want to learn about.